Thanks again for having me. I'm really excited to share this with you, and most importantly, to hear your feedback and thoughts of my research. As you mentioned, I recently completed my fellowship, and I'm just getting started as a K-12 scholar and getting started on this work. So it's a good time to share this work and hear back what you guys think. So this all began, like most things in urology, with a catheter-related issues. My interest in shared decision making started with a research project I did when I was a resident at the Minneapolis VA, which is one of the nation's 5 spinal cord injury centers of excellence. And we looked at veterans who had traumatic spinal cord injuries and how they managed their bladder if they needed a catheter, whether they had an indwelling or an intermittent catheter. And we surveyed 100 veterans, and we found that about 50% of them used intermittent catheters, and the rest were either using suprapubic tubes or urethral catheters. And we found that there had been a lot of transitions in catheter types. Nearly 30% of those veterans had tried a different catheter modality. But what's really surprised me was that the people that were most satisfied with their catheters were the ones that had indwelling catheters. And the reason people switched away from the intermittent catheter was not really for clinical reasons, but mostly because they just didn't like intermittent catheterization, or that it was inconvenient for them and didn't fit their lifestyle, or even sometimes clinicians recommended them to have an indwelling catheter. And so by the time I started this project, I'd already thought about going into FPMRS and neurourology, where a central tenet or golden rule, you would say, of how we manage neurogenic bladder is to really recommend intermittent catheterization as long as people are able to do that. And so I was really interested in this dichotomy of what I had been learning in textbooks and really what patients were ending up doing to meet their life needs. And so this brought me to search about how patients make decisions and different communication styles and decision-making in medicine. And I learned about shared decision-making, which is basically the process of balancing the best available medical evidence with patients' preferences and values to make a medical decision. And while this was new to me about 5 years ago, it's not a new concept. It actually started in 1982. There was a commissioned by President Reagan to study ethical problems in medicine. And they thought that the whole form of informed consent was not enough, it was very one-sided, and that really there needed to be more of a two-way conversation between clinicians and patients about how we make decisions to actually have an informed medical decision. Now, when we talk about shared decision-making, there's just a little terminology I'd like to go over. The first is a preference-sensitive decision. So this is a decision where there's multiple treatment options and there's equal medical outcomes for the different options. And so when we're looking at that balance of evidence or best available evidence, the evidence is not leaning one way or another. The evidence shows that multiple options might give patients equal outcomes. And so really the weight of the decision falls on the preferences of the patient. And in functional urology, I think the majority of our decisions are preference sensitive. For example, if you look at third line therapy, like for overactive bladder, the outcomes between Botox or neuromodulation are similar. And so really it's up to the patient and their comfort with the adverse effects profiles to decide. It's also similar for bladder outlet surgery if you're looking at men with similarly sized prostates for BPH, which surgical therapy to proceed with. So shared decision-making is facilitated by decision aids, which are tools designed to provide information about medical decisions, including their risks, benefits, and alternatives. But more importantly, these tools are supposed to engage the patients so they are thinking about what matters most to them. And while some people think decision aids are sort of the heart of shared decision-making, it's really just a facilitator of the process, which is an interaction between patients and their clinicians. It's important to know what shared decision making is not about, because there's a lot of misconception. It's not really about just having patients sort of have their way or have whatever they think. It really is trying to provide them with the best available evidence and work together with them to see which treatment might suit them best. If there's obviously a clear choice of what might be best for the patient's outcome, then it doesn't have to be this elaborate process, and that's not really a preference sensitive decision anyway, so shared decision making doesn't really apply. It's not letting patients decide on their own with any clinical guidance, and it's not just being nice to patients. So why is this important, and what's the literature on this? So there is meta-analysis evidence that using this process can decrease decisional regret, which is when patients feel regret about what they decided to undergo. It decreases decisional conflict, which is sort of the struggle that patients feel about whether or not they should do undergo a certain treatment. It can also increase patients' compliance with treatment strategies because they're more engaged in their own healthcare. It can empower them to be more active in their healthcare. Patients are more satisfied when they feel like that they have a two-way conversation with their clinician about the next steps. Of course, it builds trust and confidence, patients' knowledge, and it can lead to guideline concordant care. So there's all of these benefits to this process, but traditionally, when I was reading about it, there were very few studies about how we're doing this in urology. And certainly I had never heard about it until I started digging into the literature. And I haven't been out of residency that long. And so my first step when I came to Michigan as a fellow was to sort of see how we were doing in this and as urologists. And what I did is I reached out to the AUA, and the AUA sends an annual census out to all the urologists. And we added some questions on there about shared decision-making. Now, we didn't say, are you doing shared decision-making? We basically listed the components of shared decision-making and asked people to select for different situations, clinical scenarios, which things they regularly do. And I was surprised to find that there are actually at least self-reported rates of doing most of the steps of shared decision-making were high, over 75% of people. And most people didn't think there were any barriers to using this modality in their clinic. Unfortunately, the areas where we did see improvements needed were like the parts that are really most central to decision-making, which is the patient engagement. So asking preferences and values, and the use of decision aids, which can engage patients. So one of the criticism of this is that it's a survey study. So there's self-report bias, and the numbers were much higher than previously reported. So we looked at trying to corroborate this with a patient-facing survey data set. So we had surveys from some surgical CAP surveys. So these are patient satisfaction surveys that are sent out to patients after surgeries. And we had a cohort of these surveys from people that had undergone functional urologic surgery within our institution. And there are 3 questions on that survey that matched 2 domains of shared decision-making. So we looked at those domains and made a composite score, and we were really surprised to find that the numbers almost matched perfectly with the provider survey, where about 70% of patients reported that their provider had done all 3 steps of shared decision-making on this composite. And actually the rates of decision aid use were almost the same. It was 50% in the clinician-based survey and about 60% in this. In this study, we further looked at whether decision aid use was correlated with using a decision aid, and it was. So that was a nice step, because now we could use decision aid sort of as a way to a proxy to study shared decision making. It's easier to study whether a tool was used than whether a process was done in clinic. So taken together, in my first year of fellowship, I basically learned that shared decision making, or aspects of it, are more commonly used than previously thought. So it is a concept that urologists are familiar with, but there's key aspects that are maybe omitted that are central to it, which is getting patient involvement and using decision aids. And so this led to my next set of questions, which I actually submitted as an F32 grant and was funded. And I did that during my last year of fellowship. And that was to look at what kind of things influence whether a patient is going to use a decision aid. And more importantly, do these even help any sort of outcomes that are important to us, which are to us, the patient-reported outcomes. And that's different from prior literature in this area that has really focused on things that are a little bit more abstract to clinicians. So things like decisional regret or satisfaction. And really, I think what motivates clinicians is to see data that shows that this would improve patient outcomes. And so I was really fortunate to be here in Michigan, where I was able to work with MUSIC, which is the Michigan Urological Surgery Improvement Collaborative. This is a statewide collaborative. It's a quality improvement collaborative funded by Blue Cross Blue Shield, and it's made up of most of the urology practices in Michigan. And MUSIC has long tracked outcomes for prostate cancer surgery. And in 2018, they started using a decision aid as a quality improvement initiative. And so what we had was about 2 years of data of men who had used a decision aid and men who hadn't used a decision aid and had undergone treatment for prostate cancer. And the question to me was, is using this decision aid going to improve their functional outcomes after surgery? So a lot of what we do, or a lot of what I see in functional urology, is cancer survivorship, and specifically looking at incontinence and erectile dysfunction. And so I was really surprised that when we looked at what influenced the use of decision aid in a multi-level model, what we found was that who your urologist was really influenced whether you use a decision aid or not. So this is not surprising with prior literature on how clinicians influence patient decision making. So something about that specific urologist influenced patients to go ahead and use the decision aid. In contrast, when we looked at all the patient factors like demographics, their clinical cancer risk, family history, everything we can measure essentially that made clinical sense, it only represented about 2% of the odds of whether a patient used the decision aid or not. So I wanted to dig more into like what the variation was between urologists. So the first model showed us, okay, urologists have a very large influence, and I wanted to look at, but what is that influence? And so we did a prediction model where we looked at the predicted effect of urologists on enrollment into P3P, the decision aid. So in this is a caterpillar plot. Each little dot represents a urologist, and below the red line represents a negative net effect on a patient's decision to use a decision aid, and above the red line is a positive net effect. So as you can see that there's a wide variation on which direction the influence went. So some urologists had a very negative effect and some urologists had a very positive effect. So it wasn't just that the effect was going one way. So then more importantly, now we found that, okay, so urologists are key facilitators in patients using these tools. But again, what is the impact on patient-reported outcomes and clinical measures? And what we found was that in a regression model controlling for baseline erectile dysfunction postoperatively, and comorbidities, men who used a decision aid had a 56% decrease in their odds of being bothered from erectile dysfunction than men who did not. When we looked at urinary incontinence, there was still a large effect, so 45% decrease in the odds of being bothered from incontinence, but it did cross the null, so it's not statistically significant, although it is a large effect. Now the question is, why is there why does this impact erectile dysfunction, not incontinence? And to me, it makes a lot of sense. Decision aids and shared decision making affect expectation settings. There's been prior research done here that men can predict their post-operative erectile dysfunction more than they can predict their post-operative urinary function. And so it makes sense to me that if we can better provide, if the decision aid can better set expectations, then people know what to expect from their erectile dysfunction, then they're less bothered. The other thing is that when you have incontinence, it's something that affects you every single day, versus erectile dysfunction can be intermittent. And so the sort of the biopsychosocial impact is different between these two modalities. So taken together, the second group of projects showed me that decision aids can actually have a pretty meaningful impact on patient quality of life. And I think they modify perceived bother through better expectation settings. And the urologists are really key facilitators in having patients engage in using a decision aid and in shared decision making. And so, to me, this is something that I really want to bring into functional urology. Most of the research in shared decision making and decision aid has been done in urologic oncology, but it makes a lot of sense that these are the same kind of challenges that we see in functional urology, which are basically expectation settings and counseling patients. And so that's how I came to what I wanted to study as a K-12 scholar, which is overactive bladder. So I argue that overactive bladder is one of the most preference sensitive conditions. There's multiple treatment options at each tier of treatment. There's relatively similar outcome data among options for each tier of treatment, and the choice of therapy is largely based on the patient's preferences and values. And for those that are, just to refresh everyone's memory, the first line of treatment for overactive bladder is education and behavioral change. The second line of treatment is medication-based, so anticholinergics and beta agonists, which are newer. And the third line is neuromodulation with either sacral neuromodulation, which is a implantable device, or PTNS, which is a office-based acupuncture treatment, or chemodenervation with onabotulinum toxin. And so looking at the data of how these medications, how these therapies compare to each other, when you look at anticholinergics versus placebo, we think most of the studies will measure the change in voids over 24 hours or the frequency, and that's in the third column, and in the fourth column is the change in incontinence episodes over 24 hours. So anticholinergics have maybe about a decrease of 1 episode of a void, or 1 less void per day, versus placebo, and about like 0.4, like less than half of a decrease in incontinence episodes per day. And that's a meta-analysis of all the data that was available in 2006. The beta agonists are newer, and when they did meta-analysis comparing the beta agonist to anticholinergics, the effects were similar to anticholinergics. A little bit better decrease in the number of voids, but really the same, no difference in the number of incontinence episodes. So the main difference between the beta agonists and the anticholinergics is their side effect profiles. Beta agonists have much less side effects. When we think about third line therapy, we see that there's about a 3-fold improvement in the outcomes compared to the second line therapies. And that's either with onabotulinum toxin or sacral neuromodulation. And more importantly, for the preference sensitive decisions, it looks like the effect is similar between the two therapies. So there's not one that's better than the other as far as outcomes. So that really got me more convinced that this is very preference sensitive. So we have these treatments for for overactive bladder, but lots of women do not even get to the third line treatments. So we know that the road to overactive bladder treatment can be sort of an uphill climb for patients. We know that there's really poor care seeking and maybe barriers to access. Only about a third of patients with incontinence reported discussing that with a clinician, and only a fourth saw a specialist about OAB. We know that even if women or men get started on an anticholinergics, they usually don't stay on it very long. So only about 20% of women who started an anticholinergics and about 25% of who started a beta agonist were on it beyond about 4 months. So that's claims later looking at refills. And it looks, and the discontinuation for all therapy is about, by 5 months, people are not taking the medications anymore. And from claims data, we know that the median time from diagnosis to third line therapy is at least 8 months, but that's only in the very small amount of women who undergo third line therapy. So it's less than 5% of women who are seen or have a diagnosis of OAB even make it to those third line therapies that are, 3 times more effective than second line therapies. So to me, this really begs that we have a really big problems to solve. How can we bring personalized care and better treatment efficacy to overactive bladder? And I'm not the first one to propose this. There's a study, this paper a couple years ago out of Europe shows another way to, another proposal for personalized care. So on the left, or column A, is the current strategy, and column B is their proposal to basically phenotype overactive bladder and give directed therapy based on the clinical phenotype. And they really said, they really said it so well in this paper. They said the current treatment strategies will rely upon therapy invasiveness and cost rather than the appropriateness to patients' characteristics and symptoms. And I think that's really profound, because it is sort of an uphill climb with lots of trial and error for patients that can be discouraging to get effective overactive bladder treatment. So looping back to shared decision-making, the first part of shared decision-making is having the best available medical evidence synthesized so that you can counsel patients on what's out there. And that's sort of where my project picks up. So the title of my K-12 project is to explore treatment decisions and outcomes for a tailored approach to advanced overactive bladder care. And the reason I'm focusing on advanced or third line therapy is that there's such a paucity of data on this, because there's so few men and women that undergo these third line therapies. And I think it's a really, it's a huge gap in how we can maybe see who's the best fit and how we can bring these therapies to patients that are very efficacious. And the conceptual model for this study is informed by the health belief model. So this says that there's certain patient factors that inform their eventual action to get a treatment. So this can be either demographic or socioeconomic, but it can also include things like self-efficacy or how bad they think their symptoms are, and their perceived benefits and barriers to treatment. But we all know that patients aren't in a silo, and so I adapted this model and added the Ecological Framework that says that, that patients are sort of nested and influenced by other things in their environment, including clinicians, and clinicians are influenced by policies, including guidelines and payment models that really drive a lot of treatment, that can drive a lot of treatment decisions. And so the aims of my grant, or my project for the next few years, are to first characterize clinician and patient decision-making regarding third-line treatments for overactive bladder. Next is to look at patient characteristics associated with undergoing these third-line treatments. And third is to predict the change in symptom severity among patients undergoing third-line therapies for OAB. So for aim 1, this will be a qualitative aim. And so we are currently conducting patient interviews, and we'll soon be doing clinician interviews to assess the health beliefs around decision-making and expectations for advanced OAB treatment. And I think there's going to be quite a divergence in themes generated by clinicians and patients. Some things might be similar. I think both patients and clinicians will echo that severity and bother are main drivers for treatment, and that has been shown in prior literature looking at this. But I also think that patients will place greater values on their prior experiences with OAB care and how many iterations of tried and failed therapies and what their expectations of the future outcomes based on these prior experiences are. And that's really where the health belief model themes come in. And for the training aim, this will help me build qualitative skills, which are something that I haven't yet developed, and also help me integrate those into my quantitative background using a mixed methods approach. For the second aim, this will be a quantitative aim, and we will be using a retrospective institutional database that we're currently creating that has over 75,000 patients with OAB, and of those, 1,700 underwent third-line therapy. So there's quite a robust experience here. And what's unique about this database is that we have captured through the EMR symptom severity scores, including the AUA symptom score, but more importantly, what we call the Michigan Incontinence Severity Index, which has specific OAB measures, including frequency and pad use. And we'll use a multi-level model to see which factors are associated with undergoing third-line treatments. And we'll use the themes that we find in aim 1 to inform our regression models to make sure that there's things that we measure that are important to clinicians and patients that we include in this model. So based on prior literature, I think severity will be a huge driver of patient decision-making, but I think there's also going to be socioeconomic and insurance status that are going to be associated with their decisions to pursue advanced treatment options. And this will show, where policy change can guide future policy changes or advocate for, how we're thinking about OAB and who gets access to these more efficacious therapies and who can't. And for training, this will not only reinforce my quantitative methods, but help me, again, integrate it into mixed methods training. And finally, I think the aim that I'm most excited about is using this database to see if we can predict symptom severity change among patients undergoing these third-line therapies. So the thought is that we can use regression methods or machine learning methods to predict what kind of an expected symptom severity change a patient is going to use or going to have after undergoing neuromodulation or on a botulinum toxin. And I think that this will be predictable based on symptom scores and baseline characteristics. Prior groups have looked at this and haven't been able to predict it, but I think that the power has been the limiting factor, and we luckily have this large database where we can have both a test, we can split our database into a testing database to create a model and then a confirmation set. And the methodology I'm hoping to gain out of this is prediction modeling, which I think will help me in the future to answer the question of who does best with what therapy and how can we better guide treatment for overactive bladder. The impact of this, the first impact as a trainee is that it will train me and allow me to gain training in both qualitative and quantitative methods, which I think are essential to understand overactive bladder care and the treatment decisions. I don't think it's possible using just claims or outcome-based data. We really need to understand what's going on in that clinician-patient interaction. The data that comes out of this can inform clinical and shared decision-making overactive bladder. So maybe we can identify patients who may benefit most from these third therapy, third line therapies earlier in their visits, maybe at their first visit, if they have severity measures that are, you know, meet a certain criteria, we can triage those patients to say, you know, you might benefit most from one of these more advanced therapies. It also can help with patient expectation settings, which I think is so important in overactive bladder care. It's important to let patients know, you know, what they can realistically expect out of medications, and so that they know what lies ahead of them in their treatment for overactive bladder. And most importantly, you know, I'm excited about where this is going, especially in the future, and data, especially the prediction modeling, if we are able to predict change in severity, we could use that to pilot a clinical decision support tool based on prediction model, or we can look at this to see how we can model more efficient care based on perhaps selective early use of advanced therapy in people with certain severity measures. And then bringing it back to shared decision making, you know, this grant focuses on the medical evidence side, but you know, it is a goal of mine to keep looking at the patient's preferences and values and how we can balance these to really give people complete care. So that would be a next step out of this.